I'm Dr. Jasmit. I'm an assistant professor at the Aga Khan University, Nairobi. My background is in biostatistics and bioinformatics, and I have been one of the lead trainers for the EQUIST 2.0. So within the team of Aga Khan, we have a few members that were trained by UNICEF when we had initially heard about EQUIST. Those are the names over there. It's led by myself, and then Dr. Michaela, Dr. Anthony, Dr. Abdu, Mr. James, and then Prof. Marlene and Prof. William are the main heads of this EQUIST. So just a little bit of background. The Aga Khan University got a long-term agreement with UNICEF to be one of the LTA partners in October 2017. We had a global workshop and the trainers of trainees on EQUIST in December 2017 in Budapest. We did a reviewers and a refreshers training again this year in January and in New Delhi. So our initial support was with Ethiopia office. We did have a contract with UNICEF Ethiopia office where we were to give support to the Ministry of Health and the Ethiopia government on these use of EQUIST. We did 3-week workshops in Ethiopia. The first week we were in July. We went to introduce ourselves. So it was a preparatory visit by 3 members of the Aga Khan team for data collection and workshop planning to Addis Ababa. And then we did an introduction of EQUIST to the government and the Ministry of Health, and just giving them an insight of what EQUIST is and what EQUIST can do and how you guys can try and use it in your budget implementations. There was agreements on the need for capacity building at national and at sub-national levels. We wanted to focus on a sub-national level. So the first workshop was done in August. So between 29th July and 13th of August, we were all collecting the data. We had another person from Aga Khan who was updating the EQUIST Excel spreadsheet on getting the data up to mark and ready. And then the second one, so the first one we did it in Amhara region, and the second one in November we did it in NPR region. So Ethiopia was one of the countries, as Sharu had yesterday shown, how each of the country workspaces can be divided into different country workspaces. So we divided the regions. So in Ethiopia, the map is at a country level, and then instead of provinces, they call it regions. And then within regions, there is zones, and then there's districts and woredas. So the first meeting was with MOH officials and the UNICEF Ethiopia team for just us to interact with each other and understand what is needed and how we need to do. So we actually went there for the requirements of the data and to understand what the country actually captures the data and what kinds of data is available from the Excel file of the indicators that we were given. So what sources can we use? So there was disaggregated data for the Amhara region within the zonal and the district level. There was the raw DHS data, HMIS data by zones and districts. They have reports such as the newborn assessment report. They have SARA, and then they have SPA, BMONC, CMONC, and then annual reports, welfare monitoring reports, mixed surveys, MIS, LMS, annual meeting report, and then some research depository reports. So within their academic institutes, they have to give their data to the government for the government to also use it, because these are all research data. And then there's a state of inequality report. So most of the indicators that EQUIST requires, they all come from this. There are additional indicators that we even used to model the scenarios, which you can use. So if you know that you need an indicator that is relevant to, for example, neonatal mortality that is not in the standard list of indicators, you could always add that. And then we wanted to prepare the first workshop region and to understand who would be available to come for that workshop. So the first workshop, we did it in Amhara. It was in Bahar Dar. We had 3 participants from AKU team that was leading this workshop. We had 3 UNICEF leads from the country office, 2 participants from the Federal Ministry of Health, and then we had 34 participants from the different regions and the different zonal areas. We wanted to have this as a diverse background, where we had people that were from health information officers to monitoring and evaluation officers, public health doctors, specifically some that were really targeting on nutrition. So we wanted to have an understanding from everybody of how to make the best scenario possible. And we also had included a few university lecturers and professors so that we could even have an academic insight from there. The second workshop was from Bahar Dar. Based on the first experience of the workshop of not having a lot of people, we tried to reduce it, and we had 2 people from Aga Khan, 8 people from UNICEF regional office, 3 from Federal Ministry of Health, and then we just had 9 from the regional and the zonal participants. We had a lower number for the SNNPR because on the 12th of August there was an outbreak of yellow fever, which also got disruptions for our workshop. So when we started this workshop in Amhara, we did a pre and a post survey where we tried to first identify what the knowledge for health systems and for equity analysis was within the Amhara participants. So the questions we had asked that, what do you understand by the term of health management information system? If you had any training on health management system, what is the importance of data and data quality to your understanding? How do you use your data? And then what knowledge do you have on equity analysis? We did a post survey after the workshop where we asked again the same questions, and then we also asked 2 additional questions. Give us 3 comments on new things that you've learned from the workshop, and then what recommendations would you have to improve our future trainings for us. So the results were pretty much same. We got a pre-training data on data management where everybody knew the importance of the data. Everybody knew what health management information system is. 65% were previously trained on HMIS, and 46% knew about equity analysis. When we asked them about the use of data, we had 8% was just using on decision making, 16% on just monitoring, 24% on monitoring and decision making, and then 36% for monitoring and evaluation, and then 16% on planning and monitoring. So this was also allowing us to bring the topic out there that we need more precise data on district level, on zonal level, for you guys to get the accurate results. The other survey results that they wanted recommendation on improving the EQUIST training was that they wanted us to do a follow-up with the trainers. So we were just training them over there, and then they go and do their own investment cases or cases that they want to do, but they wanted us to follow up with them and continue that process of us pushing them that, okay, where's the data and all that. Internet is a problem, as Sharu had mentioned. We really had problems with internet because of the electricity power. They needed more time on practicing. When you look at the process over here, the situational analysis is a very fast process. The focus point and the target population that you choose is also very fast. The strategies that you try and do is also fast. The hard part is the bottleneck analysis. When we're doing a 5-day workshop, your bottleneck analysis usually falls on the 4th day, which the whole day they're rushing through all this very many steps, and then the 5th day they're presenting the results. So you're also bound to go this in a very fast process. They wanted to revise the service package tools, and then they wanted to also include Zonon and Voredo data, which is lower level data, and they understood that they need that. So we had an agenda just to show the way we did this for the first part. The first half of the day, we had actually given time to the participants over there to discuss and understand what the problem for the country is and how can we mitigate these gaps and how do you come up with solutions, and giving them an idea of health management information system and their agenda with their strategic planning of how to move ahead with this questions and to move forward. So the first day in the afternoon, we had then brought them to an EQUIST overview of the planning. The second day, we started them with the situational analysis, and then in the afternoon, we did a scenario building going through all the 7 steps separately. The third day is where they were practically into different groups. We had broken the groups in a way that we had a mixed population. We didn't want everybody of the same cadre to be in the same group, so we tried to shuffle them around, and they did their hands-on scenario. The fourth day, again, we made sure that they do 2 presentations for us. So they're also preparing a presentation guideline for us so that we know that they're understanding how to do the 7-step process. And then from the afternoon, we started having them to present their results and whatever within their group they have found out. Within that, we had also captured the notes and the presentations and any discussions they were trying to make, so that when we got back to Nairobi, we wanted to modify the scenarios and try and make sure we're doing the right way around. And then the last day, we wanted to also bring in again back the Ministry of Health representative and discuss with them how to move forward ahead with this and what's the next plan agenda for this. So it was the same agenda for the SNNPR region. So based on what we did, a few of the demographics for Ethiopia, the population is around 102.4 million, and this was in 2018. I think it's gone to 105 million from 2019. The proportion of under 5 is 14.7%. The crude birth rate is 31.8 per thousand population. The under 5 mortality for IGME is 58.4% deaths per 100,000 live births. The neonatal mortality rate is 27.6, and then the maternal mortality ratio is 353 per 100,000 live deaths. So why priority on Amhara region and why neonatal mortality? So this is where your situational analysis comes into play, that you want to see which region you want to target and what indicator you want to do. So the under 5 mortality rate of Amhara region is with 67 deaths per 1,000 live births, which is very slightly above the national average, but it's not the worst in Ethiopia. However, the region shows highest neonatal mortality rate, which is 47 per 1,000 live births in the country. In Amhara region, the neonatal mortality makes the highest contribution to the under 5 compared to other regions, and given the EQUIST situational analysis, we decided and agreed that we want to probably focus on the Amhara region. So this is just an overview of the situational analysis that we have. So Amhara region is somewhere around here, and when you compare your different year demographics, you can see that it is one of the highest deaths. This is the neonatal mortality rate trend, and it's also one of the high in Amhara region. And then when you compare the under 5 mortality by cause, you can see that the highest amount of the deaths in Amhara region is caused by neonatal mortality. So Ethiopia and Amhara region, the total burden, the equity frontier, and the operational. So nationally, the neonatal mortality is higher in urban compared to rural areas. In both rural and urban, asphyxia and prematurity are 2 major causes in neonatal mortality. In urban areas, congenital regions and are higher compared to rural, where sepsis and pneumonia show higher in urban regions. And then the 2 wealthier quantiles show higher in neonatal compared to the poor quantiles. We've seen a trend in Africa where the mortality rate is very high. Usually when you compare the quantile by the wealth, the wealthier quantiles have a higher value of rates than the poor quantiles. And then asphyxia and prematurity remain the 2 major causes of deaths. And then in Amhara, we wanted to focus on asphyxia as the main cause of neonatal death, both in the most and the least deprived, followed by prematurity. So this is an overview where you can see that the urban, the neonatal deaths is higher than the rural one, not too much though. When we look at the neonatal mortality caused by wealth, you can see that the quantile 4 and quantile 5, the richest, and quantile 4 is also high compared to the other quantiles. When you look at the neonatal mortality by the different causes, sepsis is the highest in Amhara, followed by asphyxia and prematurity by 10% and 7%. So the causes of neonatal mortality, the equity frontier, which equity frontier is comparing the worst region in the country to the best region in the country. That's the equity frontier. So the best region in the country was Addis Ababa, and the worst was here as Amhara region. And you can see this asphyxia, the best region was 10.3 and the least was 9.4%. So overall, using EQUIST data analysis, the three major causes for neonatal mortality for Amhara region of the most deprived were identified as asphyxia, prematurity, and sepsis. So those were the three that we really focused on to look at the strategies and the interventions that we want to focus on. So additional data related to neonatal mortality, we found out that obstructed labor is the major cause for maternal mortality in Amhara region. And obstructed labor is related to asphyxia in newborns. Sepsis or infection is the fourth main cause of maternal mortality in the region. Maternal sepsis or infection are known as one of the causes for newborn asphyxia and sepsis. And then Amhara region also shows an antenatal care for 4 visits per pregnancy attendance, which is a below national average attendance. And ANC is a prerequisite for perinatal and neonatal death. And then only 15% of the women in the region with expected major direct obstetric complications are treated in EMOC facilities, and where obstetric complications are high risk for neonatal mortality. And then Amhara region ranks the second in terms of currently married women using any method of family planning, and family planning is indirectly related to neonatal deaths. So these are the different causes of the same different what I explained for the causes of maternal mortality. And then the ANC, which Amhara was with the line over here is the national average line. And then the EMOC facilities, that percentage of women use, Amhara was even higher than the national. And then the family planning, Amhara was even higher than the national one. So conclusion from the EQUIST analysis, given the situational analysis, the most deprived population in relation to neonatal mortality was Amhara region, and the scenario was built on 3 major causes: asphyxia, prematurity, and sepsis. And the analysis of maternal mortality showed that improved access to and quality of delivery services or delivered by skilled birth attendants are important strategies with specific interventions to consider. So for example, long and difficult delivery obstructed labor is contributing to newborn asphyxia. Other causes of newborn asphyxia include less oxygen, problems with the umbilical cord, problems with the placenta, a serious infection, high or low blood pressure, baby's airways, and then baby's blood cells that cannot carry enough oxygen. So the other conclusions is that ANC4 is an important determinant to reduce the risk of maternal complications in pregnancies such as infections, blood pressures, and thus affecting the newborn outcomes. And the low ANC attendance in the region suggests that we need interventions to increase the ANC visits. And then the low percentage of the women with expected direct complications treated in the EMOC facilities are of a concern, and then given the link of them not using the EMOC facilities. So data issues that we had identified within the Amhara region that influence the use of EQUIST. One of that is that we do not have the sub-level data. So we just have the national data. One issue that we had found that national maternal mortality was said to be around 35 to 38%, where the health officials on the table told us that that is not the case for every region. Another region could be 42%, another region could be 48%, one region could be 25%. So they agreed that taking a national average for different regions is not the right answer. Urban and rural differences in the neonatal mortality within the region cannot be shown because we do not have enough data to capture that. And the situational analysis might differ depending on the data source of which we are using to enter the data. We have found that the DHS data and the data from CHIRG of IHME, they are giving different numbers of the rates. So we even have to be very careful of what numbers and rates we use when we look at these different data sets. So we have already done the step 1 and step 2, I think, yes. So that was choosing the population and choosing the disease. Now we want to look at the different intervention packages. As we had seen that there are 3 different packages. There's family care practice, preventive services, and curative services. We had chosen neonatal and infant feeding and care, family planning, antenatal care, and then integrated management to childhood illness, delivery of skilled personnel, and emergency obstetric and newborn care. Within each of those, we had chosen the particular interventions that you get to choose from. And then for the antenatal care, we had chosen all of these interventions. And then for the integrated management and childhood illness, we had chosen the interventions as seen up here. And then for the delivery of skilled professionals. And then the EMONC interventions. So when you download the Excel file, you can actually then come back and play around of what interventions you want to look at and what are the bottlenecks. So this is the bottleneck analysis where you have, these are the interventions that we have chosen and these are the bottlenecks that you want to choose. The X's over here represent the ones we have chosen. So for example, thermal care, we've chosen for accessibility on a geographic level. For thermal care, we've also given in a bottleneck for affordability. So you can come back and change and play around and you'll get your different scenarios. So the bottlenecks were prioritized based on the first scenario that was done in Amhara region. What we had done was that we had separated everybody into 5 to 6 groups. At the end on Friday, we actually did one whole scenario analysis with everybody together on focusing on one area. So we had, for practice purposes, we had divided few people to do under 5 mortality, few people to do neonatal mortality. At the end on Friday, we actually came back and did neonatal mortality for us to even understand what's going in Ethiopia so that we can come back and refine these things to show them that you can actually modify the scenarios. So specific local knowledge about Amhara region may influence the bottleneck analysis and strategies to address bottlenecks and might therefore increase the preciseness of scenario building and improve your results further. So these are the strategies that we select to address for the bottlenecks. So these are the interventions that we had chosen, and then these are the strategies that we want to choose. And the color coding is from red to green, where red is low relevance and green is high relevance. So you just have to play around again with this. And you can see that it's not a very short process. The bottleneck analysis is a very long process. So you really have to give your time to do your bottleneck analysis. So Amhara region, for the neonatal mortality, we had strategies to address bottlenecks. So under financial strategies, we wanted to give supply side financial incentives, and contracting out were identifiers as most relevant to address the bottlenecks primarily of the service-based interventions, and to support neonatal care, vouchers and insurance systems were shown to be relevant. And then for the service delivery, we found the most prominent was to give out community education and outreach services on a community level. And then for medical products and technology, we wanted to make sure that pharmaceutical stock and the management is there, because most in African countries, the availability of pharmaceutical drugs is a limitation, and we want to make sure that there's an improvement in that. And then under health force, we wanted to have leadership management and more of HR related issues, because that's also one of the issues that we saw. For governance, health system accountability, and then under information of high relevance, it's shown that we need to strengthen their health information system. So results of the analysis and the scenario building. In the total scenario, it resulted that you could avert 3,426 neonatal deaths with the interventions and the strategies that we had outlined. This would decrease the neonatal mortality rate from 50 per 1,000 to 45 per 1,000 live births in Amhara region by 2023. So this was a 5-year budget plan that we were trying to do. Out of this, 32% averted deaths are related to neonatal sepsis, 28 is related to asphyxia, and 23 is related to prematurity. And it showed with the cost analysis that 175 lives can be saved per US $1 million. And then the total cost for the investment case that builds on the above outline is about $22.2 million for a plan of 5 years. And the cost per capita is 0.96 US dollars for the scenario. So this just shows it's not as good as what Robert showed for Burkina Faso. We always want this graph to be bigger than the equity frontier, because this actually compares to your best region in the country. So our equity frontier was Addis Ababa, where Addis Ababa is doing better. So this is where you need the knowledge within the country of how do you improve your interventions, how do you improve your strategies, and what bottlenecks can you make sure that then this gap reduces and becomes, the graph becomes higher. This is the cost analysis, where this gives you your different costs based on your strategies and then your per cost capita. So the conclusion was that the results of the scenario building are much better compared to the final scenario that we had done on the last day in Amhara. So we gathered the information that we were sitting over there, came back to Nairobi and played around with the software, changed a few effect sizes. As Sharu had shown yesterday, if you shift the effect sizes up and down, your answers change a lot. And then nevertheless, the difference is still significant between the equity frontier and the one we had chosen. The aim over here is to reduce the gap between the current disease burden of the most deprived population to the equity frontier, which is the best within the region. And repeating of the process of scenario building by key stakeholders will be required to select the best scenario. So because we are not within the country, we don't understand the country very well, we need to have more frequent key stakeholders over there that can help us to make the scenarios better. The other one is to refine the data and get more data, precisely more on lower level incomes. Bottleneck causes and strategies are crucial to be defined correctly in order to achieve the most cost-effective results. And then the reiterating scenario building process is a very time-consuming process and requires very much dedicated time. As I said, you can't really finish this in a one-day process. And then the training and the capacity building of stakeholders who have never been introduced to and trained on EQUIST system should not be combined with the actual investment planning process based on the use of EQUIST. And then the planning process would require a smaller team of EQUIST that is trained well with the national, regional, and sub-regional stakeholders that come and do the reiteration of the scenario process and are getting closer to the equity frontier impact figures, which we're happy that the Federal Ministry of Health in Ethiopia has chosen a lead of different people from different regions to take this lead and move forward with this. We further went ahead and tried to map out a theory of change, because I think implementation and investment cases do require a theory of change where you just show your different bottlenecks and then what you're trying to do. We want to reduce the neonatal mortality by 10%. We want to increase coverage by 85% in the intervention packages. What have we done and how do you achieve that? Thank you.